Alright, so let's talk about fungal infections for a minute. So if we look at previous videos, we might have looked at treatment for fungal infections in the video dermatological therapies, where we look at briefly antifungal medications that are given in fungal infections. And in the case of fungal infections, they can be serious or mild. In most cases, they are mild, and these tend to be the ones that are superficial types. So we have a case of superficial fungal infection. There are cases of mild types, and then we have the serious ones. There are the deep fungal infections. So that's one way to classify fungal infections, in which we could give fungal medications accordingly, whether topical or systemic. Another way to classify fungal infections could be according to the site and according to the fungi. So let's look at some examples of systemic fungal infections, along with just one example of deep fungal infection. Let's start with the superficial fungal infection. So with the superficial fungal infections, there are many types. The most infamous ones are dermatophytes, that's number one. Number two is the yeast, and examples of subtypes of yeast are Candida albicans, as well as Tinea versicolor or Pityriasis versicolor. And then once we finish with the superficial fungal infections, we're going to talk about the deep fungal infections, which is known as Madura foot or mycetoma. Okay? So let's start with the superficial fungal infections. Fungal infections that occur superficially at the level of the skin, the epidermis. So let's start with the dermatophytes. Now, regarding the dermatophytes, it is a superficial fungal infection in which a fungi also known as a ringworm will infect the skin superficially at the level of the epidermis. And there are many types of ringworm, which is not a parasite, it's just another name for the fungi. There's many types of names or many types of ringworm for the dermatophyte species. They can be microsporum, trichophyton, or epidermophyton. Regardless, they all have the same results clinically and the same treatment. And regarding this ringworm, which is by the color red, this fungi likes to strive on the dead cell. So you can look at this dead cell. This dead cell, meaning a cell that doesn't have a nucleus, this is known as your corneocyte. And your corneocyte contains keratin. And that's the target site of this fungi. This fungi likes to attack the corneocytes at which layer of the epidermis? The stratus corneum layer, the outermost layer of your epidermis. This very layer consisting of constantly shedding, constantly filled with corneocytes, which are your dead cells that contain no nucleus but a lot of keratin and filaggrin. And that's the target site of this fungi right there. It feasts upon it and it stays there. Now the question is, how does this fungi reach the skin? Contact. Either the human who was infected with a dermatophyte, either he came in contact with H, another human being infected with dermatophyte, came in contact, or A, contact with an animal, or S, contact with the soil. Regardless of how human might have occurred, regardless of any contact transmission a human might have had, whether it was with a human being, whether the contact transmission was with an animal, or it was within a soil, the fungi will enter inside the skin and it will target, again, the corneocytes, the dead cells in the stratum corneum layer of the skin. Okay? And once it attacks these cells and affects them, when it affects these cells, it will lead to what? Inflammation. It will lead to a pathognomonic change in the skin. And it can lead to skin lesions, a lot of primary skin lesions. And in the case of fungal infections, they're quite unique, and we'll see it. So here we have a drawing of a human being, and there's a lot of clinical features in different colors. So we're going to start with the dermatophytes. Now the dermatophytes, their clinical presentation will differ according to the site. So we have what is known as a tinea. So when you think of the term tinea infection, it's the same as dermatophytes. Tinea infection caused by dermatophytes. And the clinical presentation is a rate of dermatophytes, CF, it differs according to the site. So we have many different names for many different sites. So if you have a dermatophyte infection in the scalp, it is known as Tinea capitis. You can think of this guy wearing a cap, like mine, Tinea capitis. A tinea infection or a dermatophyte infection affecting the skin of the scalp. And this is very, very severe, mind you, because if someone has Tinea capitis, then in that case we have to give him systemic antifungal, especially most commonly griseofulvin. One of the best ones, first line, given as a systemic antifungal because this is a very serious disease. And the problem with tinea capitis is that when you look at his clinical presentation, it will be very similar to a case of alopecia. A patient might, or a doctor, he might mistake this for a case of alopecia. But you will see in the case of tinea capitis, especially in pictures, the patient may have remnants of hair. But in the case of alopecia, no amount of hair. And that's exactly what's happening in tinea capitis, infection of the scalp by dermatophyte infection. There will be affection of the hair, especially in the scalp region where a lot of hair will be lost, and there will be the presence of a lesion. And what is that lesion seen exactly in any tinea infection? Well, let's say in this tinea capitis infection, I did a zoom in exactly what this lesion looks like. And this lesion shows to me an itchy, flat or raised lesion. Alright? So I have a patient who might complain of itching, very mild itching, and he has a lesion that might be flat, meaning it could be a macule, or it could be a patch, more commonly a patch, or it could be in the form of a raised lesion, more commonly it's maybe in the form of a plaque or a papule, alright? So more commonly it could be in the form of an itchy, flat, or most commonly raised lesion that is reddish in color, erythematous in nature, and it is also scaly in appearance. So let's say most commonly in any dermatophyte infection, whether in the scalp, tinea capitis, you'll have the presence of an itchy, erythematous, scaly plaque with, most importantly, raised active borders. You see these color in purple? Let's say this represents the borders, which is the margins of the lesion. Now in the case of fungal infection, the margins are very, very active, meaning they are raised. Not only are they raised, they're also more red, more erythematous, or more scaly in their appearance. Basically, the raised margins of this lesion, it's more active. It is more raised compared to the center. It is more erythematous than the center. It is more scaly in appearance compared to the center. And why is that? Why do we have a raised active border in fungal infection? Because these are the sites where the fungus is most hyperactive. The fungus is more hyperactive around the lesion more than the center. So if you have a case of a patient with an itchy, erythematous, scaly plaque, okay, with raised active borders, you are likely to think of what? Fungal infection. Nothing specific, but at least you can think of a fungal infection as a possible diagnosis, okay? And in the case of tinea capitis, dermatophyte infection of the scalp, you'll see this lesion along with remnants of hair, very small amount of hair, which somebody might mistaken for alopecia. And this is a very serious clinical presentation of dermatophytes in which we have to give this patient what? Systemic antifungals, and not topical. Most common systemic antifungal is griseofulvin, okay? Now there are other clinical presentations of dermatophytes, okay? Other clinical presentations of dermatophytes can involve the trunk. So you can think of this guy who's wearing a red t-shirt that says T-Corp. T-Corp is Tinea corporis, or corporis. Tinea corporis, it means infection of the trunk. So if there's infection of the trunk, alright, or the extremities, then you can consider it as Tinea corporis, which is dermatophyte infection of the trunk. The same presentation. If you have dermatophyte infection of your legs, or let's say on your feet, let's say specifically on your feet, a dermatophyte infection of your feet is known as Tinea pedis, P-E-D-I-S. It is also known as athlete's foot, and basically they call it athlete's foot because this region is prone to humidity. It is prone through sweating, especially among athletes that play sports for a long period of time. And as you know, fungi likes to strive in areas where there's high humidity, or when there's a lot of sweating, a lot of wet areas where it can thrive upon. So that's why they call it athlete's foot. But regardless, back to the point, athlete's foot is another name for Tinea pedis. And in the case of Tinea pedis, again, you'll see the same lesion, whether in the feet or in between the toes, okay? So that's pretty much it. Of course, The thing that we're also afraid of, another serious infection, where we want to give this patient systemic antifungal rather than topical antifungal, is a case of onychomycosis. If you have an infection of the nail bed, if a patient has infection of the nail bed by a dermatophyte, like in a case of onychomycosis or paronychia, then this is a case where no, we have to give this patient systemic antifungal rather than a typical topical antifungal, alright? A topical antifungal like conazole, for example, which we can give in the case of tinea corporis, for example. If you also have a dermatophyte infection of the face, then you have what is known as tinea facie as well, okay? That's pretty much the presentation of dermatophytes, or the presentation of tinea infection. A tinea infection of the scalp, tinea capitis. Infection of the trunk, tinea corporis, wearing a t-shirt. Infection of the feet, tinea pedis, which is known as Astley's foot. If you have an infection of the nail bed, onychomycosis, serious and systemic antifungal. Tinea capitis, serious antifungal. And there you go. If you have an infection, dermatophyte infection of the face, tinea facie. Okay? So there's many different clinical presentation according to the site, but the lesion is the same. This one right here. An itchy, raised, typically raised like a papule or a plaque, an itchy, erythematous, scaly plaque with raised active borders. Okay? Clinical presentation of a fungal infection, especially in the case of tinea. Okay? So this is how you diagnose, this is really how you mostly diagnose tinea infection or dermatophyte infection through clinical diagnosis. So we're going to go ahead and talk about diagnosis and treatment. But I just want to make one thing clear. I want to make one thing clear. The diagnosis and the treatment for tinea, the concept, it is the same as fungal infections. So the diagnosis and treatment for dermatophyte, it is applied also the same for candida infection. It is also applied the same for tinea infection, versicolor. It is also applied the same, not almost the same, but almost, some of it is also applied the same in case of Madura foot. So the diagnosis and treatment for fungal infection is not exclusive to just dermatophyte infection. It's basically represents any fungal infection, okay? So before I talk about diagnosis and treatment, let's look at other clinical presentation of other fungal infection. So we finished with the dermatophytes, right? We finished the dermatophytes. Now let's talk about other fungal infections. For example, the yeast, another type of superficial fungal infection. And yeast can be divided into candida as well as tinea versicolor. Let's talk about tinea versicolor. Tinea versicolor or pityriasis versicolor, this is not from dermatophytes, it's its own separate thing, alright? And this is typically caused by a Malassezia, a type of fungi known as Malassezia fungi infection. And in the case of this one, basically you have a fungal infection in which a patient is asymptomatic. However, when he undresses himself, he notices in his upper extremities, or in his upper trunk, there's the presence of a patch, right? A brown, well-demarcated patch. Again, a well-demarcated brown patch present in his upper extremities and his upper chest. He's asymptomatic. So if your patient may come to you with that presentation, you might think of tinea versicolor as your fungal infection, alright? So tinea versicolor, from the color itself, you might see a patient come to you with well-demarcated brownish patches or macules in his upper extremities or in his upper trunk. And typically these patches, they can also be erythematous in nature, okay? They could be erythematous and scaly in nature, but most commonly the more dominant color is brown, okay? So you can have a case of an erythematous scaly macule or patch that is brownish in color and well demarcated, but the patient is asymptomatic. The most he might complain of is itching, but that's typically rare. Typically the patient is asymptomatic, okay? So that's tinea versicolor. The diagnosis is mostly clinical. You don't need to do anything more to diagnose for tinea versicolor. Unless we go to a specific investigation, we'll come to it in the end, okay? So that's for the tinea versicolor. Now the last part of the superficial fungal infection is candida. Now candida is a part of your commensal flora. It is part of your flora inside your body, it's normal. So if you have a candida infection, this is a case of immunocompromise. This is a case of a patient who has immunosuppression like diabetes, like organ transplantation, like AIDS, anything that causes compromisation or compromise of the immune system. And if your immune system weakens, then there will be opportunistic infections. And an example of opportunistic infections are candida infections. So in the case of candida albicans infections, basically this patient will be presented with what is known as skin or mucosal lesions. So if a patient has a skin lesion, in the case of candida, like let's say around the skin, anywhere in the body, besides the lips, the mouth, and the genitalia, anywhere in the body, let's say, if a patient has a skin lesion in candida infection, he might present with erythematous patch. Let's say an erythematous patch, all right? And this patch is characterized by, if we show by the red color, this patch is basically characterized by what is known as a satellite lesion, all right? So in the case of candida, if you have the skin lesion in here, you might have the presence of multiple satellite lesions. It means you have a lesion, a group of smaller lesions that are rotating around the big lesion. So you might have an erythematous patch right here, on an erythematous macule, and surrounding it is a bunch of papules or pustules, right? A bunch of smaller skin lesions. That's why they call it satellite, like a satellite that's rotating around it. So you have a bunch of papules or pustules here, raised satellite regions that are surrounding an erythematous patch. And this is involving the skin, all right? This can involve pretty much the skin, all right? But in the case of mucosa, if you have a candida infection affecting the mucosa, such as in the angle of the mouth, like angular cheilitis, or in the mouth, oral candidiasis, or in the case of the genitals, genital candidiasis, these types of mucosal candida infections are very, very characteristic of white flax. So basically, let's think of the most common one, oral candidiasis. So here we have in the blue color, in his mouth, oral candidiasis. And in the case of oral candidiasis, oral thrush, especially in children, you'll see the presence of white flax, all right? You'll see many, many, many white flax. Snowflakes, they look like snowflakes. So you might see the presence of white flax that are very, very easily scraped off. You can easily scrap them off and take them for a microscope. And that's a very, very important distinction, because you might see a similar skin disease that might have a similar presentation, but they're not scraped off. And that's lichen planus. So in oral lichen planus, you might have the same presentation, but the difference is in lichen planus, you cannot scrap off these whitish plaques. But in the case of oral candidiasis, yes, you can, okay? And in the case of oral candidiasis, the satellite lesions, they're not as obvious. But you can see satellite lesions, especially in the genitalia. You might see, again, an erythematous patch, and surrounding it are surrounding satellites, satellite lesions, raised satellite lesions in the form of papules or pustules, all right? And that's a very diagnostic key feature we have to keep in mind in the case of candida infection, okay? So that's for the candida albicans infection, the clinical presentation. Patient may complain of itching, patient may complain of difficulty in swallowing in case of oral thrush, especially in children. But when you look at his mouth, he opens his mouth, you'll see the presence of white plaques, very easily scraped off white plaques. They can scrap it off and say this is oral thrush. Or in the case of genital candidiasis, let's say, in the case of genital candidiasis, you can see the presence of basically the presence of an erythematous patch with raised satellite lesions. Satellite lesions can be in the form of papules or pustules surrounding the primary lesion itself. Okay? You can see it in the genitalia, and you can see it especially around the skin in general. Okay? That's pretty much it for candida. Please, let's remember satellite lesions for a minute. Okay? Now that we finished that out of the way with candida, now that we finished the superficial fungal infections, alright? Now let's go to the deep fungal infections. This is by the green color. Let's say we look at the patient's feet. Let's say we look at the patient's feet, all right? His feet in general. And in this patient's feet, it is swollen. It is erythematous in nature. His feet is swollen and erythematous in nature, and you might suspect the presence of a subcutaneous mass, especially in a subcutaneous mass here, like in this green color, which if we zoom in, the subcutaneous mass has multiple sinuses, openings, multiple openings that are draining out pus. So if I see that, then I am suspecting in this patient as my differential diagnosis a case of Madara foot or mycetoma. Now, Madara foot is a deep fungal infection. Everything else was superficial fungal infection. But in Madara, it is a deep fungal infection in which, due to penetrating wound, when a patient has a deep wound or a penetrating trauma to the skin, in which it allows a fungi or a bacteria, this can be fungi or bacteria, so let's focus on fungi for a minute. It can be in a case of a deep penetrating trauma or wound in the skin that allows the fungi to enter inside the skin, especially at the level of the dermis. And if that happens, that can lead to the development of a subcutaneous mass. And this mass can get bigger and it can have multiple sinuses, all right? Multiple opening around it. And this, especially the most common site, is in the feet. If you have penetrating trauma in the feet, you might eventually develop a subcutaneous mass with multiple sinuses in the green color. And these sinuses drain out what? They drain out pus. And the thing about that's very specific, the thing that's very specific for Madara foot is that these sinuses, when they drain out pus, you can take these pus and you do investigation and you'll see that these pus, they contain what is known as tiny discharging granules, all right? These tiny little sacs. So if we look at this picture here, if we do a zoom in this picture, this is a sinus, right? And this sinus is draining out pus. If I do investigation, if I look closely at this pus will contain this black colored thing. And this black colored thing, in the case of fungal cause of Madara foot, it is a known case of tiny discharging granules. So if you see the presence of tiny discharging granules from purulent discharge, multiple purulent discharge from a subcutaneous mass involving the feet, then this is a diagnostic feature of Madara foot or mycetoma. Now remember, mycetoma can be caused by a fungal infection due to deep penetrating wound, or it can be caused due to a bacterial infection, which also enters the layer of the skin, the dermis, through a penetrating wound. But for the sake of this video, we'll focus on the fungi part. The diagnostic feature is the same, regardless of the cause, okay? Now, the thing is, I will look at the diagnosis and treatment for deep fungal infection. It is different from the superficial. You see, in the case of deep fungal infection, I can't just give the patient topical antifungal and that's it. No. This one requires surgery, all right? In case of Madara foot, I have to do debridement. I have to do debridement of the skin. There's gonna be a lot of dead tissue. So I have to do debridement of the skin, and then with investigation, if I suspect this is a fungal cause, I'll give this patient systemic antifungal. But if I suspect a bacterial cause, I'll give this patient what? Systemic antibiotics. So in the treatment of Madara foot, the diagnosis is a clinical diagnosis along with investigations, like a discharge or whatever. And then I do surgery, debridement, once I confirm the diagnosis. And once I figure this is a fungal, I give him systemic antifungal. And if I figure this is a bacterial, I'll give him systemic antibiotics, okay? This is for the diagnosis and treatment of Madara foot. It will be different from the superficial fungal infections, okay? So now that we finished with the green color, let's go back to the diagnosis and the treatment. It is the same for any fungal infection. The diagnosis for most of these superficial fungal infection is clinical. I can clinically diagnose it by my eyes. However, there are certain things that can confirm my diagnosis further. For example, skin scraping. I will do scraping of the skin lesion, right? So if I have a lesion here, like in tinea capitis or tinea pedis or anywhere, I will do skin scraping of the lesion. But where will I scrape the skin in the case of fungal? In the center or around it? No, in the borders. Because remember, the borders of this lesion in fungal infections, these are the regions where the fungus is most hyperactive. So I will scrape part of the skin that is in the borders, okay? I will take this part of the scrap, this part of the skin that I just scraped from this lesion, and I will put it in a slide under light microscope. And before I look under my light microscope, I will apply KOH. It is like a stain. I'll apply KOH, which is exclusive for fungus. I will apply KOH, exclusive for fungus, apply it on the skin scraping that I've done, put it under light microscope and see what I'm looking at. And I will see the characteristic feature of a fungi. It might be in the form of a hyphae. Could be a septated hyphae or a non-septated hyphae. Regardless, I can know what is this fungi. I will know immediately whether this is a fungi or not. And if this is a fungi, which type of fungi. Okay? So that's one way of diagnosing any superficial fungal infection. I could do skin scraping, especially around the elevated raised borders, and apply KOH, put it on light microscope, and see the fungi itself. Another one I can do is clinical diagnosis. The third thing I can do is culture. I can put this on a fungal culture and see whether it's able to grow or not. But the last diagnosis, which is very specific for fungus, and it is an office procedure known as a Wood's lamp. Here in Wood's lamp, this can be another way of diagnosing for fungal infections. In the case of Wood's lamp, the idea is that I will have a lamp, okay? This is a lamp. And basically what I will do, I will turn off the lights around me completely. And I will have this light working. And I will put this lamp right here, not the light. I'll turn off the light and I'll have this lamp with me. And I will put the lamp on the skin lesion, alright? And the idea is when I put this lamp on the skin lesion, it will reflect back to me a light. And the color of the light will determine for me what might be the diagnosis. If I see the color golden yellow, then this can confirm for me specifically tinea versicolor. If I see a golden light color with the lamp in front of me, in the front of the skin lesion, this is tinea versicolor. If I see a greenish color, this can confirm for me tinea capitis. So I can basically put a lamp on the scalp of the patient, turn off the light, I see a reflective light in the form of color green, tinea capitis. But this can also be used for other things like vitiligo. If I see a patient who might be suspected with vitiligo, a depigmented patch or macule all over his skin, I put the lamp and I might see a milky white color, for example, okay? So it has other uses as well. But the wood lamp can be used mainly for fungal infections, especially in case of tinea capitis with the green color, or tinea versicolor with the golden color as an example. So it will give me a reflective light from this lesion, and it can help me in diagnosis, okay? So now that we finished with the diagnosis, these are the list of diagnoses. The last one is treatment. Regarding treatment of any fungal infection, the first thing you do is patient education. A lot of fungal infection really comes from things that are preventable. So typically, a lot of fungal infection come from contact, right? It's like especially in dermatophytes. So if they come from contact, then I must educate the patient. I educate the patient to stay away from objects that can be touched. Like in the restaurant, somebody touched something and contaminated it. Then a person touches this. So objects that can be easily touched by everybody else and easily contaminated, and you touch it and you rub it all over yourself, that can lead to a fungal infection. So that's what patient education is. You educate the patient about a fungal infection, what are the signs, what are the symptoms, how you might get this fungal infection, and how to avoid it. So you tend to avoid personal objects as much as you can, or at least clean these personal objects, okay? So that's what is based upon with fungal infections, patient education and working on prevention. Besides that, you give this patient antifungal, topical or systemic. Most of the time, in the case of superficial fungal infections, you'll give this patient topical antifungal. Like in the case of, for example, dermatophytes, you can give, for example, this patient ketoconazole, or in the case of candida, you can give this patient nystatin, for example. But if you have a case of tinea capitis, no. In the case of tinea capitis, you have to give this patient a systemic antifungal, most commonly griseofulvin. And there's also other indications for giving systemic antifungal. Like in topical, mostly we give topical. It is safe, it is reliable, it is very effective, and it can get the job done with superficial fungal infection. But if we have a case of a deep fungal infection or something that's very severe, all right, or let's say we have a fungal infection that spreads all over the body. So not just in the trunk, it spreads on the face, it spreads on the arms, it is extensive, the lesions are big, they're not small, they're big, they're extensive, or the patient is immunocompromised. Then in cases such as these, or in the case of mother of foot, another one, in cases such as these, we give the patient what? Systemic antifungal. fungal. We give the patient what? Systemic antifungal. Systemic antifungal can be given in cases where an infection can be serious. Either we have a fungal infection that's expensive, it spreads all over the body, more than one site, and the lesions are big. Or we have a patient who's immunocompromised, then that's a big flag, big red flag. Or the patient might have a case of Madara foot, or a patient might have a case of tinea capitis, or a patient may have a case of infection of the nail bed, like onychomycosis. Onychomycosis is a complication, infection of the nail bed, like from dermatophytes. You have to give this patient systemic antifungal. Or a patient might have paronychia, another abnormal nail change with infection with fungi. So these are basically specific cases where you might give this patient systemic antifungal. But typically, most cases, if this patient has a lesion that's small, the patient is not immunocompromised, basically the opposite of what we've mentioned or what the patient might not have, then you can give this patient what? Topical antifungal. Okay? You give it to him until the fungal infection resolves itself. Okay? That's pretty much it for fungal infections, and I'll see you in the next one.